Hi, welcome to our IHS channel. My name is Marcio Nattan. I'm a neurologist in São Paulo, University of São Paulo, and it's my pleasure to welcome here Dr. Miji Lee, who is professor of neurology at the National University in Seoul, South Korea, and Dr. Diogo Edelmuth, who is a radiologist in University of São Paulo in Brazil. And we're going to talk about a theme that is evolving so fast, which is how to manage a patient with SIH. So I'll start with you, Dr. Mijili. How do you see this very concept of SIH? We're talking that it is a syndrome that presents with neurological symptoms, but how do you concept the very idea of SIH nowadays?
Yeah, we considered it intracranial hypotension because it looked like intracranial hypotension because patients had a worsening headache at standing. But we now all know that the problem is not inside the brain, but it's arising in the spinal dura. So it's a spinal dural disease. So we have shifted our focus from the brain to the spine. So we image the spine for the diagnosis and we follow up the spine for the outcome. So from my experience that we have patients who are well remedied after blood patching. So they are still having no symptom at all and they are crystal clear, but still there is a CSF leak here. So we recommend to follow up patients with a spinal imaging and aim to the radiological remission, complete radiological remission first. And then patients may have some remaining headaches. So we call it post-SIH headache. So we can manage them because we are headache experts. So we can manage them like with something, medications used in migraine prevention or tension time like headaches because we treat phenotypes after treating the cause of the headache.
Yes, absolutely. And thinking about achieving this diagnosis to then think about the remission, once we see a patient with orthostatic headache, which is the most common, but not all of them will present, what, Diogo, you think should be the first steps in investigating to confirm the syndrome and start management treatment for these patients?
So, Marcio, nowadays we know that radiology is essential in the workup of these patients. So even from the get-go, sometimes the suspicion of SIH comes from the brain MRI. We know that many cases have like very non-specific syndromes as well as the most typical presentations. So if you start, sometimes you just have the suspicion because of the brain MRI. But if your suspicion comes clinically, then from the get-go you should order always like a whole neuroaxis MRI. So you need the brain and you need the whole spine MRI, because sometimes if you're just looking at the brain, you will miss a few cases of epidural fluid that you would only see on the spine MRI. After that, so once you have established that there is an SIH, and that is the diagnosis of the patient, you could be achieving that through the brain or through the spine. You will also be evaluating which type of CSF leak they seem to have. So whether they're what we call SLAC positive or SLAC negative, so whether they do have epidural fluid in the spine, and that will guide you to investigate dural defects or a proper CSF leak or a CSF venous fistula. So those would be basically the two main types that would be investigated by an invasive myelography.
Thank you. So in the end, you start the investigation with the brain MRI and ideally also the spine MRI. And then you have this idea, if it's a SLAC negative, it might be a type 3, as you said. If it's SLAC positive, you're maybe talking about a type 1 or 2. And I think this is very important because it guides you for the decision of management, right, Dr. Mijili? So if you're talking about a type 1 or 2, which kind of approach would you be thinking to promote for your patients?
Actually, many patients have type 1. Type 2 is relatively rare compared to type 1 in our population. And type 1 arises from the ventral dura. So ideally, we need to identify where is the exactly the dural defect located and target that location. But it's not always possible in every setting, and it's not always possible when we need it because there's some delay, there's some appointment, long waiting list. So I would start with some blind epidural patching. We don't call it blind anymore. So we call it non-targeted blood patching. So we target the level within the leg. So as much we do the blood patching, the patients will have more likely to be remedied both clinically and radiologically. But as I told you before, it should be done very early in the disease course. After doing very early non-targeted epidural blood patchings, ideally 2 or 3 patchings, we follow up radiologically patients if their flag is remedied or not. So if not, we go to the dynamic imaging like DSM or ultra-fast dynamic CT myelography, and we target directly the defect, like the targeted epidural blood patching, and we can consider surgical correction if the targeted blood patching fails.
And how long after the last blood patch will you be ordering the control neuroimaging?
Often it shows immediate response. So if it's very successful, many cases shows immediate radiological remission after 1 or 2 days of blood patching, but there can be some delayed response, as you can guess. So we image them immediately, and if that not remedied, we follow up the patients 2 weeks later. If we have enough time, every patients are different time windows. So at that time, we decide how to approach these patients after localizing the leak. If the patients have time means within like 3 months after onset. So we recommend them to get targeted blood patching. And again, we image immediately after blood patching and 2 weeks again to decide whether this patient should require like surgical correction or not. For patients who had already long-term disease course, we directly send them to our neurosurgeon.
That's a very useful clinical question that we get a lot. And I share the experience that it's usually fast, that it's like will resolve, although not always. A few times it will take a few weeks in my experience, but that's not the standard. So most people would say, I won't image in a few days because it won't change my practice. So I'll just save the system and the money. But I mean, you're probably sitting on very great data that I'm eager to see someday.
Actually, it's not possible because it costs a lot in our medical system. But time is the dura. So if we have to decide the decision very early in the disease course, we may have to do it very quickly after treatment to see what is the outcome from the previous treatment.
Very interesting.
And then moving to the type 3 fistula, once you have a patient with the clinical symptoms of SIH and you do the brain MRI, it is positive, and then you go for a spine MRI and you find no SLAC, so it's SLAC negative. These cases, should we always be thinking about type 3 fistula, and also how to think about this investigation, because there are technical aspects that are crucial for achieving the diagnosis, and we have seen an important increase in the prevalence of type 3 SIH with this improvement of technical performance, right?
Yeah, that's exactly the case. So if you have a positive brain MRI or a very high suspicion of SIH and you don't have any epidural fluid in the spine, you're basically thinking about CSF venous fistula. So there are very rare exceptions to that idea, but mostly you will be investigating it, and mostly you will be finding a CSF venous fistula. And this is significant because, one, it changes how you approach the myelography, so you have to have a specific technique for finding these. And also it will change our management plan. So you will be probably less likely to be offering patches, just non-targeted blood patches to these patients because they respond more poorly to them. So it's less likely that you'll be actually closing the CSF venous fistula indefinitely. And yeah, so I mean, there are different approaches to diagnosis, but also to treatment. Once you diagnose them, you can go to transvenous embolization. You can even try patching, but with more specific, like targeted and glue patching, or even surgery. So it can help a lot. And these are patients that we couldn't even diagnose a few years ago, and now we can actually cure their disease.
And it's not that the myelo-CT is a new exam, but the technique has changed in order to improve this yield finding of these type 3 SIH. Could you briefly remind us on what is specifically the technique that you're going to use if you're suspicious of a type 3 SIH?
So yeah, so the first CSF venous fistula, they found it at Cedars-Sinai over 10 years ago, and it was with the same protocol that they used to diagnose ventral leaks. But what really changed was when somebody had the idea to put the myelography on the side, with the patient on the side during myelography. If I'm not mistaken, that was around 2019 that was published. And
so in lateral decubitus.
Lateral decubitus. So that's the main thing. When you have them, there are a bunch of like more or smaller specifications to the examination. But basically, when you have the patient in the lateral decubitus and you have a very dense and ideally early, but mostly very dense layer of contrast on the side of the thecal sac, then that little uptake of venous CSF will get seen on imaging. If your contrast is very diluted, then the little bit that goes into the vein, it's just not seen.
Finally, a question for both of you. What is the experience that you have seen lately in treating a patient with confirmed type 3 SIH? What are the possible approaches?
So there are basically three treatments that are offered today, and depends a lot on the institution, on the country, so it does vary, but they're basically targeted patching with glue, not only blood. There is transvenous embolization, so an endovascular approach, and there's surgery. And there are no head-to-head comparisons, but most of the data would point to like an increasing efficacy, probably. So patching, then embolization and surgery, although that can be questioned. And we see all types of possible prognosis to these patients. So we see patients who get one treatment and they're cured for good, as far as we can tell so far. And there are people who will like partially respond, and there are people who respond and then recur. And recurrences in these cases, unlike other types of leaks, they can be on the site of the original CSF venous fistula. Maybe it wasn't entirely closed, but they can also recur at different sites. So that has also been very well published by now.
How has been your experience with those cases with confirmed type 3 fistula?
I wouldn't take this question because I'm not much experienced with type 3, and Diogo already nicely summarized the treatment approaches. I take the type 1. So the many patients eventually require surgery, and the microscopic surgery requires laminectomy, and neurosurgeons had to manipulate the spinal cord to approach the ventral dura. So it potentially causes complications like paraplegia, but it's not actually common in a very experienced setting, but there requires some kind of learning curves to get that. So we recently started to do some endoscopic approach for these patients. So it didn't require laminectomy. We drill the neural foraminal space, and then approach our endoscopy directly into ventral epidural space, and put the artificial dura there intradurally and extradurally, and it worked. So I would like to introduce this new approach to the surgical treatment for patients with type 1.
This is very good news for our patients, because if you improve safety and reduce the time of internal time of these patients, this would be very good news. And we see that surgical treatment most likely is very effective. So it's very interesting to know this is evolving in your experience with that. Any final remarks for us to close to our audience from IHS?
Yes. So I guess the main take-home points would be that we should always be imaging the whole neural axis. That's very important so that we don't miss many of these cases, and that they should be followed up, just like Professor Jimmy Lee said. They should be followed up with imaging, not only clinically, because we know we will miss many of the patients that are not cured, and they may be with very few symptoms, but they will have a persistent leak often, and that can lead to some serious complications. But also they can have like mild persistent symptoms that might be ignored and just pushed off to the side as, you know, a common headache and something that could potentially be treated.
How about you? Any final remarks?
Yeah, I would like to add something that we need to classify patients. We need have different approaches to acute onset patients and chronic percent leaks. So for acute patients, we need to avoid any potential intracranial complications like brain sagging and herniation, and that's potentially fatal. So we need to do everything to stop the leak at certain point, even if it's not completely successful, but it helps to a certain point. So that's a rapid approach for the acute patients, and we need more tailored approach for the chronic patients. So we need to localize the leak and find them the most suitable treatment.
So thank you so much. I think you can see how incredibly dynamic this field is, and it's fascinating because we're talking about patients that usually they are very impaired in quality of life, and we can many times help them improving a lot. We are learning so much now, ongoing, and thank you for watching. Thank you, Professor Mijeli and Dr. Diogo Edelmuth, for being here with us. I hope you have enjoyed this content.